Mm. Good morning, good afternoon, and good evening, everyone, wherever you are in the world. In behalf of FIP, I welcome everybody in this very important activity we have for today, a webinar on a very special topic, pain management and counseling. How can pharmacists support patients in achieving better quality of life? I am Leonila Ocampo, a member of the FIP Community Pharmacy Section Exco, and I'm from the Philippines. A pharmacist for quite a number of years, have been into different areas of practice, majority of which is in community pharmacy practice. Some announcements. Let's have some announcements. The webinar is being recorded and live streamed via YouTube. The recording will be available on our website, www.events.fip.org. You may ask questions using the question box provided, and you are welcome to provide feedback to webinars@fip.org. Now, I would like to invite everyone to please become a member of FIP. It's very important and it's worthwhile. It's worthwhile to enlist as a member of FIP. And you can log on to www.fip.org/membership.registration. So you'd be able to access to a number of things that a pharmacist would need as a member of FIP. As I've mentioned, today is a very important event that we will have, which we would like to thank Beatrice for supporting this activity, this event, through an unrestricted grant. Thank you so much, Beatrice. And of course, we also would like to thank our three powerful speakers who would be discussing three important topics relative to pain management. So they will be introduced as they would come in to share the topic that they will be discussing. So our learning objectives for today are the following. We have three. One, we would want to list evidence-based pharmacological therapies for chronic pain that pharmacists can recommend or provide. We also would want to discuss non-pharmacological therapies in lifestyle changes. Pharmacists can counsel on how to improve pain management. And third, demonstrate collaborative skills to optimize therapy for pain patients, including assessment, counseling, referral, and communicating with other providers. So to continue on, we will have these poll questions. So you can pick your answer. Which of the following have not been shown to influence person's experience of pain? So you chose from the four choices given. Okay, so 67% of our attendees now answered none of the above. All influence a person's experience. Okay. The second question, which of the following is not a primary goal of chronic pain management from a pharmacy practice perspective? So you have the choices there. You can choose one of the four given. No. So we have 70% answering or who answered maximizing the prescription of high-dose opioids for pain. Okay. So we move on to the third question. Third question says, NSAID should be avoided in, you have A, children with fever younger than 7 years old, B, people with renal impairment, C, patients with autoimmune musculoskeletal conditions, and D, patients with COVID-19 infection. So you pick your choice. Okay, so we have letter B as the choice of many people with renal impairment. That's answered by 67% of our participants today. So thank you very much for actively participating. And then we move on now to our first topic. Our first topic will be discussed by Dr. Jack Collins. Dr. Jack Collins is a lecturer and a community pharmacist in Sydney, Australia. His research interests include self-care, mental health, health policy, health equity. Jack is an EXCO member of the Social and Administrative Pharmacy section and was the 2018 recipient of the FIP-YPG Young Pharmacist Award for professional innovation for his work exploring implicit bias in pharmacies. Now help me welcome our speaker, Dr. Jack Collins, who will discuss on the topic assessing patients for pain, questions and tips for pharmacists. Welcome, Dr. Collins.
Thank you very much for that introduction, and hello everyone. It's fantastic to have so many of you online with us today. Okay, so moving on, we'll start off with a bit of background about pain. So pain is an invisible symptom of many conditions. Unlike other things which we can easily measure or we can physically see, pain is a little bit more abstract when we're dealing with it. This is further compounded by the fact that there's many different types of pain, and these are influenced by numerous factors. So on the right-hand side there, you can see kind of what we would call the biopsychosocial model of pain, where we know that someone's pain experience is influenced by a huge number of things. We have, for instance, their genetics, if they might be living with comorbid, perhaps depression or anxiety, how much self-efficacy do they have, and how much control do they feel that they have over their pain or their condition. And then we also have some social factors as well, such as their socioeconomic status, and what social support network they have. And so there's a huge number of these very complicated factors that all interplay together to result in someone's overall pain experience. It is also very difficult to quantify pain. We can't just assign it a number and know that's how we're going to treat it. And it's highly individual. Each person's experience of pain may be very different to the person next to them, the patient in the next bed. So if something's quite difficult to quantify and it's quite highly individual, then therefore it's inherently challenging to manage. So pain is common and it's a feature of many different conditions. And so there's a number of different ways we can classify pain. We can classify it by its duration. So is it acute or chronic? Its location, whereabouts in the body is the pain? Is it in a particular joint, or perhaps it's in the lower back? The pathophysiology, so what's causing the pain? Is it neuropathic pain, or is it something more like our typical nociceptive pain due to an injury, for example? And then also the intensity. So some people might describe certain pain as being very severe versus other pain they might consider to be something like a dull ache. So we use all these different terms, different ways that we can think of pain when we're trying to classify it. Thinking about chronic pain in particular, which we'll hear a bit about in the next couple of presentations, it's quite hard to kind of get a good idea of what the global prevalence of chronic pain is, because people might not always report it. There's stigma associated with it. And if it's not something that we can visibly see, it means that it may not be picked up by clinicians if it's never reported by patients. So the global estimates that I saw, which unfortunately were a little bit dated, I think they were about 10 years old, was that approximately 10% of the world currently is living with chronic pain, and that number is increasing. So that is something that we will encounter more and more of in our practice as time goes on. It can be anywhere as high as 25% in certain populations. So I think it was in the US, they estimate in some populations up to 25%, or 1 in 4 people live with chronic pain. As we age, chronic pain prevalence also tends to increase. So older people are more likely to live with chronic pain than younger people. And if we move away from that chronic pain, which we might consider to be pain lasting 3 months or more, we also have a huge number of people that we see in pharmacy experiencing acute pain. And I'm sure everyone in their practice has probably encountered people living with those 2 different types of pain. When we think about where we might encounter patients experiencing pain in practice, I kind of thought about it in 3 major groups, and how we approach pain, the questions that we ask, and the way that we interact with patients can differ slightly depending on the circumstances in which we're seeing them. So we might, for example, see them for an initial presentation to a community pharmacy, and that would typically probably be for acute pain. So people walk in, they may have a sports injury, for example, a headache, some kind of injury, lots of really common presentations of acute pain, and we're the first healthcare professional that might encounter that person. So we need to do an adequate assessment to figure out what's going on and how we can best help them manage that acute pain. That doesn't mean, however, we don't see people with chronic pain for the first time in the pharmacy either. People who are experiencing chronic pain might not have ever spoken to another health professional about it and may present to the pharmacy requesting some assistance. Otherwise, you might be perhaps reviewing a patient in hospital and they're experiencing pain. So you may speak to them about their pain and optimal pain management if that's your role in a hospital setting. Another setting where we might deal with patients who are experiencing pain is dispensing a prescription. So that could either be the first time if they're presenting with a prescription for some kind of analgesia, or it could be if we're dispensing a repeat prescription or a refill. So that's another opportunity to engage with people. The third kind of time we might see it is during a medication review. So for those of you that do medication reviews in your practice, whether that's in pharmacy, in someone's home, there's certainly opportunity there to discuss medicines in a bit more detail and get a bit of a better picture about that person's pain experience. There is evidence for pharmacists in doing medication reviews and supporting pain management. However, unfortunately, we're not quite sure whether or not that translates to meaningful clinical outcomes. So still some unanswered questions there. So the questions that we ask and how we conduct an assessment of pain differs largely on the setting and purpose. So depending on those 3 different situations, we may be asking different questions. If we have a long time in a medication review, we have more time to delve into more detailed aspects. An acute initial presentation, not quite so much time. So the questions that we ask will be different. The type of pain that someone's experiencing will also influence the questions we ask. If it's acute, then there's things that we're probably more interested in about onset, what else is happening. If it's chronic, then we may become more interested in how it's actually impacting that person's day-to-day life, for example. We're going to run through some key areas that we might want to cover if we were questioning these people, so some specific questions we might consider asking. And we'll also have a look at some tools that we can use to help us if we are going to do this in our role. Again, I just want to reiterate that pain is highly individual and dynamic. So there is not one size fits all approach to speaking to someone about their pain and their pain experience. So if we are making a pain assessment, we need to undertake optimal history taking. We need to try and elicit as much information as we can. Depending on the setting that we work, that could differ. So for some of us, we may have quite detailed clinician's notes available to us. We may be able to see quite a detailed history for that person. For other circumstances, we may just not have that information available to us. So the patient in front of us or their carer, if that's the situation, is one of the most useful tools that we have accessible. It's really important that we tailor whatever questions we are asking to the person in front of us and their needs. Things we might want to consider is, what is their health literacy status? Are they able to communicate with us about their pain and what they're actually experiencing? And so the way that we're phrasing questions, is it a way that can be understood by that person? And do we perhaps need to change our approach if they're not quite understanding the questions that we're asking? Any communication challenges, so that could be an intellectual disability, for example, or difficulty in hearing, and how can we get around that? What else can we use to get around some of those challenges that we might encounter if we are trying to make a pain assessment? Are there any support persons present? Do we need to engage them? So tailoring our questioning always to the individual situation that's happening in front of us. Of course, we're always going to ask our usual history-taking questions. So I'm not saying not to touch those. Our usual things that we would check for any medicine that we're supplying: who is it for? What other medicines or medical conditions are they living with? What allergies and so on? We would always cover those. It's more about the things that are a little bit more nuanced and a little bit more specific to when we're dealing with pain. So what I really would like to discourage is that we don't end up treating history taking like a checklist exercise. And that's a little bit of, if we think about some of the acronyms and things that exist in the pharmacy world to help us with history taking, some of you may have heard, for example, about Socrates, which is an acronym where each of the letters stands for a different aspects of pain that we might ask about. These things exist to help us think about what questions we might ask, but what happens when we get into this habit is we just treat it like a checklist, go, yep, I've asked about that, I've asked about this, but we're not really taking that information in, and it's about what are we doing with the information as well. In chronic pain in particular, I think it's important that we're going to build rapport with the individual in front of us, and I think treat it more like a conversation than an interrogation. So by using this checklist, we can really quickly, rapidly fire through lots and lots of different questions. People might feel quite overwhelmed. There's no context for the questions. And it may feel a little bit like, they're in trouble, they're getting interrogated for something. There is a huge amount of stigma around pain, particularly chronic pain. And so treating it more like a conversation, making sure that person feels really safe in front of you, may also be a lot more helpful and ensure that you have a more productive encounter with that person. I think it's really important also that we really involve patients as partners. So what are those person's expectations and what would they like to achieve from their therapy, for example, or non-drug treatment, whatever it is that you're discussing with them? What are they hoping to get out of it? And making sure that those expectations are met by whatever we are recommending, or that the expectations are kind of revised if they're perhaps a little bit too ambitious for the therapy that we're providing. And make sure that we're always screening for red flags, which means we may need to send someone back to a medical practitioner. So that could be slightly different depending on the exact circumstances that we're dealing with, but probably particularly important when we're dealing with an acute presentation where someone has not already been reviewed by a medical practitioner. So if you're the first port of call for that person, make sure that you're looking out for any signs that might require them to be medically reviewed rather urgently. And I can see that Andrew has popped into the chat a link to the Wikipedia page on Socrates for those of you that are not too familiar with that as one of the acronyms that are taught when we're taking a pain assessment. When we're looking at some of the more pain-specific questions that we might ask someone in addition to our standardized regular history-taking questions, things like the location, so that might help us with differential diagnosis. So whereabouts is the pain? When did it start? Was it brought on by anything? Was it sudden or was it gradual? Are there any restrictions in movement? Is the person still able to normally move their limb, for example? Pain intensity, which I will touch on in a moment about how we can talk to someone about that. Is there anything which makes the pain better or worse? That can sometimes help us with our differential diagnosis. Trying to get someone to describe what it feels like. So people might use different terms. They might say it's really sharp, or it feels like a bit of a dull ache. Some of those terms can help us figure out what's going on. In chronic pain in particular, we might be very interested in how the pain is impacting someone's ability to carry out their daily activities. If they're telling you that they're really not able to walk, it's making it difficult for them to work, that means that it's really quite impactful on their life and certainly impacting their quality of life. So you might want to work with the person to set some goals around how you can manage their pain to restore some of that function. Screening out for any other associated symptoms, again, particularly in an acute setting. If someone comes in, for example, they tell you they have a sore, stiff neck, they also have a fever and they can't look into light, we might be worried about something like meningitis. So I can't give you every example, it's quite context specific, but that's an example of how associated symptoms can help us out as well. Does the pain go anywhere else? So is it radiating? Is it referring pain somewhere else in the body? Again, that can help us with some differential diagnosis in certain situations. And is there any pattern in the pain coming or going or getting better and worse? Is it worse in the morning? Is it worse when you do a particular thing? Those kinds of things we might want to have a chat to people about. When you're supplying medicines or doing a medication review, it's really important to have a discussion around the expectations of the medicines and ensure that there's some familiarity around how to use them. So people may have some misconceptions around medicines, such as how long they take to work, or if they should only use it when the pain's bad. If there's medicine for breakthrough pain, at what point do they need to use that? So if someone's using, for example, gabapentinoids for neuropathic pain, that's something that should be taken regularly and may take a little while to work. People might have misconceptions that they expect to take it, and much like an opioid, it will work quite quickly. So having those kinds of discussions and making sure that people are really quite clear and familiar with what to expect from medicines, an important role of us as pharmacists and medicines experts. Identify if there's any concerns about therapy, because that can create a barrier to adherence and therefore optimal management. And make sure that there's a clear discussion around how the medicines have been used already. If medicines aren't working, perhaps it's the pattern of use, and maybe encouraging that person to keep a pain diary if they're due for medical review could also be useful. If we're trying to measure how severe someone's pain is, we may choose to use a scale. So there's a number of different scales which exist, and they have their advantages and disadvantages. We can use them in hard copy. We might be able to verbally administer them, but they all have their fallbacks. These face type ones are often used in children. We have this one which has no numbers. People just pick a spot anywhere. Each of the scales has been shown to be validated for pain use, but I think whether or not it's useful really depends on the circumstances. Some clinicians say, I'm only interested in using this to look at how pain fluctuates over time. It's less useful as a one-off. So it's hard to say whether or not there's a hard and fast to always use these tools, but they are something that is available to you if you think you need assistance in assessing pain severity. If you're doing a medication review, there are also more in-depth style tools, and I've popped the references here, so when you can re-access this in the slide deck a little bit later, you can look at these in more detail. But they're quite useful because they have a place where a person can draw on a body where someone is experiencing their pain. And then there's questions in this one on the left-hand side, there's questions where they rate the severity of their pain, how it's impacting their day-to-day activities. The one on the right, they can use different words to help describe their pain, as well as how often it occurs, what it feels like. And these have both been validated for use. So these are great options if you do happen to do more in-depth consultations with your patients. So unfortunately, the tools, scales and questioning protocols that we use tend to ignore the bigger picture, and that's that the person and their pain exist in a world that's happening around them. So we're largely ignoring quite a lot of the psychological and social factors that come along with pain. And there is a high significant amount of comorbidity of mental health disorders and chronic pain, for example, and it's kind of, there's an interplay between them. So Depending on the context, it may be appropriate to try and delve into some of those other factors as well, seeing what kind of social supports people have, because it can influence the way that they experience pain. And of course, really key to establish what that person would like to get out of their pain management, and perhaps set some goals if that's something that fits within your practice. So that could be short-term, but it could also be long-term, making sure that those are mutually agreed upon between yourself and the patient. So the more number of comorbid conditions you are, so if you have chronic pain, you're more likely to have a number of comorbid physical and mental illnesses, and depression and anxiety, as I mentioned, may worsen pain and in turn be worsened by pain. So the management of those other conditions is really important if you are communicating with a prescriber or other healthcare professionals about a patient living with chronic pain. And you may want to consider strategies that can improve those comorbid conditions, because that may also then improve that person's pain experience and their overall quality of life. Thinking about the language that we use when we're speaking to people with pain, it's really important that we not overly carefully consider it, but do consider the language that we're using. We don't want to feel like we're stepping on eggshells, but it certainly has been shown that stereotyping negative language can really negatively impact individuals who experience pain. There's already a huge amount of stigma around chronic pain, and people may feel that stigma against them if you're using negative language or quite emotive language, like saying the person's dramatizing their pain or they're being dramatic or overly emotive about their pain. And that includes in clinical documentation. So even if you're writing notes to your colleagues, it's best to try and avoid some of that stigmatizing language, because it can really then perpetuate that stigma between healthcare professionals. And it also means that people themselves can develop stigma against themselves, known as self-stigma. And that can really be heightened if there's a whole bunch of clinicians around that person using some of this negative language. Another thing to consider is minority groups and certain biases. So unfortunately, people from certain minority groups, such as racial or ethnic minorities, women, may be less likely to be given adequate pain relief and have their pain managed differently. And this can be due to biases, both implicit and explicit, and or misconceptions regarding pain in these people. The studies have shown that, for example, some people believe Black people have thicker skin, so experience pain differently to Caucasians. It's not true, but it is these kind of false beliefs that are perpetuated in healthcare providers. So just being aware of some of these differences and biases to make sure that they're not sneaking their way into your practice when you are managing people living with pain. And this is a prime example. So FIP have launched this report on the role of pharmacists in closing the gender pain gap. This was launched earlier in the year, and the webinar from the launch of this document is available on the FIP YouTube channel. If I get a sec when I finish talking, I'll pop the link to that in the chat as well. But you can also scan the QR code if this is something that you'd like to learn more about. So bringing that all together, that whirlwind tour of pain assessment, pain is really complicated and people's experiences of pain are influenced by a huge number of factors. It's not as simple as what is just causing the pain, and that's your experience of it. It's important to ask relevant, tailored questions when taking a history and attempt to understand the needs, goals, and expectations of the individual in front of you. There are conversation and language guides available in certain countries that might suggest some questioning and language that you can use when you're speaking to people. So we're obviously on this webinar practicing in a huge number of diverse contexts. So I would encourage you to do a little bit of research, a bit of looking around in your own practice context to see if those things exist, because they may be useful for you. And thank you very much.
Thank you very much, Jack, for the very insightful discussion. And now we will move to our next speaker, Dr. Bhuvan Casey. Dr. Bhuvan Casey is an academic and researcher in the field of pharmacy. He currently serves as a lecturer at the Queensland University of Technology. His research is primarily centered around chronic pain and the development of holistic strategies for its effective management. Dr. Casey's work specifically examines the role of the pharmacist in this context and analyzes the outcomes they contribute to. Welcome, Dr. Vovan Kisi, to discuss the topic pain relief in patients with chronic pain.
Thank you very much. Good morning, good evening from wherever you are. Thank you very much to FIP for providing me this opportunity to share my experience. I work with some of the PhD students, a lot of patient groups, practitioners, pharmacists, and a lot of pain specialists. So it's so nice to share some of my experience around chronic pain. And my job has been made quite easier by our earlier presenter, Jack Collins, who provided very well background regarding the pain and then some of those complexities when it comes to chronic pain. So let's jump in. So I'll be focusing on chronic pain, the complexities and the understanding of chronic pain. For today's talk, I'll first delve into the chronic pain and its complexities. So from a pharmacy practice perspective, how we can understand chronic pain is quite important. Then we'll look at 6 core concepts of pain. After that, I'll very briefly cover what pharmacists can do from a patient, for a patient with chronic pain. I'll try to share example of one of my PhD student who run a systematic review and meta-analysis looking at pharmacist services for chronic pain. And finally, I'll talk about some futuristic approach or some implication for pharmacy practice when it comes to chronic pain management and what roles pharmacists can play or how can we actually help patient with chronic pain. So let's begin by asking this question: what is it like living with chronic pain? So we are talking about a pain that persists and the pain that people have to live with for life, or the pain that is quite on and off and affects all aspects of your life. So it means people can't have quality time. They can't spend quality time with their friends and families because pain is affecting all that aspect. It hinders or it bars their activity. Maybe their walking is compromised, their activity of daily living is compromised, and it will eventually affect their productivity and all aspects of life. Furthermore, it affects their emotion, mood, sleep, and severely impact quality of life. So that's the chronic pain. So it affects all aspects of a person's life. So that's why we have to kind of understand the chronic pain and its multifaceted aspects. Then only we will be able to kind of deliver the service needed for this patient from a pharmacy practice perspective. So let's look at complexities and chronic pain, or why is chronic pain such a complex issue or phenomenon. So it involves multiple body systems. Sometimes the pain can be due to a clinical problem or disease like rheumatic arthritis, osteoarthritis, chronic migraine, or it can be due to injury. Or there is this involvement of various body systems. Likewise, your pain is affecting sleep, mood, mental health, immune system. So that's why the pain is first associated with different conditions. Second, it's affecting various conditions like sleep, mood, mental health, etc. Furthermore, when we look at complexity, there is heightened response to normal pain signal. So in chronic pain, even the normal pain signal can be amplified and people can experience a heightened response. So these are some of the factors that contributes to complexity when it comes to chronic pain. Furthermore, if we look at some of those mental health aspects, for example, chronic pain is multifaceted because of the subjective nature. Each patient experiences pain in a different way. There are diverse underlying causes and a diverse coexisting health conditions. So having a population kind of approach and treating everyone might be quite different. And that's what brings in complexity. Now, from a pharmacy practice perspective, balancing medication use is quite important. Right selection of medication, making sure that the analgesic and other pain relieving medications are used appropriately, managing medication related harm, or even opioid risk tolerance, etc. So that balancing medication use is quite, we have to get it quite right when it comes to chronic pain management. For example, for a normal disease, you just choose the medication, doses, frequency, and make sure the person adhere to that. And you try to manage the medication related problem. But when it comes to chronic pain, you have to kind of individualize is how this medication can bring about pain relief in that person, and all those things has to be factored in, and that adds another layer of complexity. So effective chronic pain management requires a holistic approach that includes both pharmacological and non-pharmacological management, addressing this complexity or complex patient conditions. Now, let's look at the 6 core concept of pain. The 6 core concept of pain I've taken from the Macquarie University's 6 core concept of pain education tool. So if I have to sum up the 6 core concept of pain, the first idea is the interpretation of pain by brain. So we have pain signal, brain interprets it. Now, we can't solely just like kind of rely on tissue damage. So we have to take into account of the fact that pain is an interpretation by the brain. So brain interprets the pain signal. Likewise, pain or pain signal can be modulated. So what does that mean? Pain intensity, sometimes it may not correlate with the extent of tissue damage. Maybe the tissue damage is more, but the pain intensity might not directly correlate, especially when it comes to chronic pain. So we might have to look at inflammation and other things that's contributing to pain. Likewise, pain is influenced by thoughts, activity, sleep, stress. So mental health of patient with chronic pain is very important. So that's why sometimes the pain makes the person like kind of worsens the stress, and stress feedbacks to the pain. So there's this kind of cycle, and we have to understand, and what we need to take into account is that mental health of the patient with chronic pain is an important aspect. Likewise, when it comes to chronic pain, it's an indicator of deeper issues with the nervous system, and we need to have a different approach when it comes to treating chronic pain, because it's quite different. And as we have already seen, the complexities, underlying causes, the nature, etc. And as a pharmacist, we need to be aware of tools beyond medication. Of course, medication are quite important, but we need to understand and appreciate the fact that there are therapies and ways beyond medications. And of course, when it comes to chronic pain and using medication, there is a limitation on how much of pain relief or how much we can help for the people or for the person with chronic pain. With that background, now let's look at the multidisciplinary approach to chronic pain management. Chronic pain is complex and multifaceted. That's why we need to look at and address the psychological factor, environmental factor, social factor, and other various factors contributing to chronic pain experience for the person, number one. Number two, so when we are looking at all these contributing factors and multifaceted nature of chronic pain, that's where we need to see beyond pharmacists who are the other healthcare professionals that can help. For example, a physicians or a general practitioners can make the treatment plan. Likewise, pharmacists can help with medication review, medication education. Likewise, occupational therapists can help, physiotherapists, psychologists, etc. So that's why we need to look at multidisciplinary team and how we can contribute to chronic pain management. And again, when we talk about the multidisciplinary approach, we have to take the patient, or we have to put the patient at the center of that approach. And again, this approach, it helps educate the patient, and at the end of the day, we have to help the patient self-manage their condition, because now we are dealing with a patient who have to kind of manage their pain and carry out their normal daily life activities. And that's the fundamental appreciation we have to have. And if we can have that multidisciplinary approach, we can reduce pain and improve the quality of life. So this is a systematic review and meta-analysis that one of my PhD students did. So we run the numbers, we look at the service and interventions carried out by pharmacists, and what were the outcomes when it comes to chronic pain management. So when we look at pharmacists' role in chronic pain management, we found that pharmacists were involved in medication review, opiate stewardship, patient education, and in the domain of patient education, pharmacists who were doing medication-related education plus lifestyle and daily care-related counseling, etc. So now let's look at some of those services and what were the outcomes when pharmacists were involved in or were providing services for patients with chronic pain. So the first one, medication review. In the domain of medication review, in our systematic review and meta-analysis, we found that pharmacists did medication review. They assessed the drug allergy, adverse drug reactions. They made recommendations for changes in medication. They helped tailor the drug therapy for patient, because each patient is quite unique and you have to tailor it, not just for the dose and dosing frequency. You also have to look at other comorbid condition, how well they can cope up with that medication. You might have to look at the interaction, etc. And identification of medication related problems and untreated symptoms. Just I want to kind of stress on one of the point, tailoring drug therapy. For example, when we are treating chronic neuropathic pain, and if the person has got, if their sleep is affected by chronic neuropathic pain, then when it comes to selecting the adjuvant analgesic, for example, we have amitriptyline versus pregabalin. Maybe because the pain is affecting sleep, so maybe a low dose amitriptyline may be a better choice of pharmacotherapy because it will help with their sleep. So that's how we need to kind of individualize and work out, and how we can help in best selection of medication for that particular patient. Likewise, in the systematic review and meta-analysis, we found that pharmacists, they collaborated with various healthcare professionals as a part or as a multidisciplinary pain management member. They did medication review, patient education, opioid stewardship, etc. And it kind of improved pain score, pain and disability index, symptoms of anxiety and depression. And when we look at the other intervention, it was educational video. Some of them did education on pain medication and pain management. So there are two kinds of education. One education solely related to medication or pain management medication, analgesic, etc. And other one is regarding the general pain management. And we found out, so there was some improvement in patient's medication, patient pain knowledge, but not functional status. Now, let's look at it further. So when we look at pain score or pain intensity, we found that pharmacist involvement in the team or pharmacist services help reduce the pain intensity score. Furthermore, in the meta-analysis, when we did a subgroup analysis, it showed that pharmacist intervention was more effective if the intervention was at least 3 months or longer, which again, if we look at chronic pain, since it's around for like kind of long time, so that's why having an intervention for a longer period of time is quite essential. And the takeaway message is that, of course, in the community, when you are working with a patient or a person with chronic pain, you have to provide that service on a long-term basis, because we are dealing with persons who are living with persistent pain. However, when we look at other aspects like physical functioning, mental health, anxiety, and depression, pharmacist-led intervention had a mixed impact. And again, when we look at a pooled estimate, we found that pharmacist-provided intervention had minimal effect in terms of physical functioning of the participants. And again, if we look at the role of pharmacists, our role is mostly revolves around the medication, managing medication-related harm, etc. So the parameters like pain score, etc., will have impact. But when it comes to the physical functioning, etc., maybe like a physiotherapist or any intervention by physiotherapist would be quite beneficial. And again, this shows that, of course, in some domain we can quite help, and in some domain there is definitely a role for like kind of physiotherapists and others, etc. And again, especially when it comes to mental health, anxiety, and depression, there was minimal effect. So when we look at the outcomes of pharmacist intervention in chronic pain management, we found out two important things. First, the patient were satisfied with the involvement of pharmacists in their chronic care. And secondly, healthcare professionals also, they felt positive about pharmacist involvement in pain management. Now, if I stretch it further, and if I look at it from a practice perspective, and if you, I do kind of interact with various patient groups, and when they have to deal with that persistent pain for lifelong, if a pharmacist can have that compassionate and empathetic approach and help them with their queries, help them with their medication, etc., they are very happy with that, because at community level, people are living with chronic pain. The access to a specialist isn't that what we call that accessible, because there are various referrals and barriers in different settings. So whatever we can do, patient is quite the persons living with chronic pain are quite appreciative. And again, when it comes to healthcare professional, again, in the general practice clinic setting, in a pharmacy attached with the GP clinic setting, etc., there is definitely role, and they are quite appreciative about the role pharmacists can bring in when it comes to helping a chronic pain, a person living with chronic pain. So let's try to kind of sum it up and try and sum it up as an implication. So the first and foremost point from a chronic pain perspective is that our approach to managing chronic pain should be comprehensive. Why should it be comprehensive? Because we need to look at both pharmacological as well as non-pharmacological approach. So that's why it has to be comprehensive. Secondly, when it comes to chronic pain management, having a multidisciplinary and collaborative approach is always best. So what does it mean? If I'm a community pharmacist, I need to know who are the other healthcare professionals that can help. For example, physiotherapist can help. Likewise, if someone has a mental health issue, cognitive behavioral therapist can help. Let's take an example. A person living with rheumatic arthritis or osteoarthritis, they have knee pain and they have to carry out their daily life activities. Now, when we bring in occupational therapists, the simple, like the measures done by them, like increasing the height of the working table, having a stool when a person is doing gardening, having a cane to support walking, etc., can be of tremendous help to the person living with chronic pain. So that's why we need to know who are the other health professionals in the system that can help. Now, how can we relate it to our practice? In practice, somebody comes with chronic pain, you have to kind of know, okay, if they have some maybe mental health issue or when to refer, who are the other persons that can help. So you have to know who are the other healthcare professionals that work in the health system and that can help the person living with chronic pain. Then comes the patient-centered approach. Now we have to let the patient decide. Why patient-centered approach is important? Because the person has to live with that persistent pain for life, right? They have to manage pain and carry out the activities of daily living. So until and unless the person is empowered enough to manage their condition, they can't carry out their daily life activities by managing the pain. So we have to put patient at the center of our plan and have to tailor the therapy. We have to kind of see what works for them. We have to see how they respond to the analgesic or pain pharmacotherapy, who can help with them, how we can schedule the, let's say, occupational therapies, physiotherapy, how we can help them manage the breakthrough pain, etc. But at the end of the day, we have to put the patient at the center of care. And what we are doing is that we are helping the person living with chronic pain to carry out their daily life activities by managing the pain, and we have to kind of empower them. So that's why having a person-centered or patient-centered approach is very, very important. Now, when it comes to medication, there is definitely a big role. However, when it comes to chronic pain, there is a limitation or there is a limit of pain relieving medication can help. So that's why how we counsel that and how we pass that message to the person is very important, because then that's how they can plan. So that's why we also need to appreciate the fact that there are other non-pharmacological approaches that can help the person. So that's why we need to understand the limitation of the medication and also the important role of other healthcare professionals that can help to the person living with chronic pain. As I have already covered, persistent pain means that a person might have to live with that pain for quite long, or maybe pain can be quite on and off. So at the end of the day, they have to carry out their daily life activities or manage activities of daily living despite of pain. So that's why we have to kind of help them manage their pain and carry out daily life activities. So that's where some of our pharmacy service, when it comes to medication management, personalized treatment plan, medication safety and monitoring, there is definitely role for pharmacists. But again, we have to kind of individualize it, tailor it for the person living with pain, and we have to help them manage their medication so that they can take their medication in the right manner, in an appropriate way, and kind of promote quality use of medication. For example, a person might have a surgery and they are discharged from hospital with some opioids. Now, what can we do as a pharmacist? We can talk to the person, have a detailed history, and see what are the chances that the person might end up having persistent use of opioid, or might end up, let's say, having opioid addiction, etc. So what are other factors? We can have a look at those factors. We can then maybe monitor a regular follow-up session and have a very good plan to slowly bring them down on that opioid medication and then take them off that medication, for which our intervention or our service at discharge or discharge counseling or discharge medication review or discharge, our intervention at discharge is very important. Or when a person is being discharged from hospital, we can provide those services. Next, the important aspect is counseling and education. Again, when it comes to counseling and education, we are very, very well trained in the area of medication management. But again, in the area of like kind of, let's say, general advice on mental health and other aspect, maybe we might have to train ourselves better. For example, we might train ourselves on keeping pain diary, managing your negative thoughts, how to kind of go for a gradual improvement cycle, etc. So there are these focus counseling models and tools. Maybe we might have to adapt and learn some of them, because referring them to a cognitive behavioral therapist or psychotherapist or psychologist always might not be possible. So if they are coming to your community pharmacy together with the medication, if we can have some of those focus counseling and education session, it will be quite helpful for the people living with chronic pain. And last but not the least, we are assisting patients in establishing a realistic expectation regarding pain and analgesic. For example, we might need to abandon the term like painkiller, because there is nothing called painkiller pain, especially when it comes to person living with chronic pain. If you say painkiller, pain will go away, then you are setting unrealistic expectation, because we have seen people living with pain for long. So that's why you have to first have an empathetic approach. You have to kind of appreciate the fact that someone is living with a pain, and it's quite persistent pain, and it's quite disturbing, and it affects all aspects of their life, number one. Number two, setting a realistic goal when it comes to analgesic and other medication is very, very important. Otherwise, if we say painkiller, your pain will go away, this will treat all your pain, maybe we are setting unrealistic expectation. So in a nutshell, chronic pain is quite complex because of the associated factors, subjective nature of pain, the way people experience pain differently, its impact, etc. And we have to have a collaborative and multidisciplinary approach. Thank you.
Okay, so thank you very much, Dr. Bhuvan. Pain is indeed complex, and as Dr. Bhuvan said, is multifactorial in nature, that multidisciplinary and collaborative approach in management is necessary. So we move on to our third speaker, Professor Andrew McLaughlin. Andrew is a pharmacist, academic, and researcher with experience in clinical pharmacology and the quality use of medicines. He is head of the school and dean at the Sydney Pharmacy School, the University of Sydney. Among other things, Andrew serves on national committees related to human research ethics, medicine safety, medicines evaluation, and anti-doping. He is actively involved in clinical trials and evidence synthesis related to the management of musculoskeletal conditions. So let's all welcome Andrew to speak on the topic, opioids and pain relief, pros and cons of opioid therapy versus anti-inflammatory treatment. Welcome, Andrew.
Thank you very much for that introduction, and also thank you to the previous speakers. I'd like to add my welcome and thank you to everyone joining us today. So three main aims for my talk. I'd like you to learn more about NSAIDs and opioids and when they're appropriate to use. I'd like to address some of the current evidence of when these medicines are used in two very common painful conditions, musculoskeletal conditions, low back pain and osteoarthritis, and hopefully give you a better understanding of some of the harms and potential benefits of using NSAIDs and opioids in these conditions. Just before we start, though, I'd like to declare that I do receive funding from a range of sources from government. I do collaborate with a number of pharmaceutical companies and disclose this. I've been involved in providing consultancy and education. I've also been an investigator on a number of clinical trials that all have interesting names, mainly in the area of low back pain, sciatica, and osteoarthritis. And as mentioned, I'm involved in a number of committees. And of course, the views that I share today are just my views. I should also say that, of course, I'm an academic and not a clinician. And it's great to see the many pharmacists who have joined from around the world and your clinical perspective. So please forgive me for focusing on the evidence and research rather than clinical practice, but hopefully you can see how it might translate. I'll keep that in mind. I'd like to talk broadly about that idea of the quality use of analgesic medicines today, and it's three simple things. Choosing the right management option, and as our previous speakers have highlighted, sometimes that could be non-pharmacological. And from some of the questions that have been popping up, I've been answering, it might be a range of different medicines. We do need to choose a medicine that's suitable for someone based on their history, and I'll highlight this in two cases. And when we use that medicine, it's about using it safely and effectively. And of course, that often is about the right dose and the right dose form. Before we dive into selecting medicines, I wanted to highlight a point that's already been made, that it is often older people who are more likely to experience pain. And often it's amidst what we would call comorbidity. So you can see here data from the Australian Institute for Health and Welfare. So it's data from Australia, I apologise. But it highlights the idea that many people living with a painful condition, particularly a musculoskeletal condition such as back pain or arthritis, will also commonly have other comorbid problems. Cardiovascular disease is right up there. And this starts to have implications for how we might choose a medicine and managing those comorbidities. So that's part of my message today. You'll see in younger people, that's often comorbid with a mental health problem, which could have implications for whether we would choose to use an opioid. So if I start with the first of the medicines I've been asked to talk about today in the short time that I have, I'd like to focus on non-steroidal anti-inflammatories. And this is a study that's about to be published that we've been working on in the context of what is the best anti-inflammatory for people living with osteoarthritis. And you can see from the title, it very much focuses on how to manage this with comorbidities. Now, just a reminder, of course, the pharmacology of NSAIDs is really disrupting this cyclooxygenase pathway. COX-1, of course, is constitutive. It's there all the time. COX-2 is inducible. And we know that we have medicines like Celebrex, celecoxib, which are COX-2 selective. But of course, the prostaglandins and prostanoids like thromboxane have important roles in our body. So when these are disrupted, we are walking a fine line of not only reducing pain and inflammation. We're also potentially disrupting body systems, leading to the risk of side effects, which we'll talk about as well. So just on the NSAID side effects of interest, of course, we know these drugs can have a range of effects on a lot of body systems. Most importantly, of course, probably down the right-hand side here, we've got the effects on the cardiovascular system to increase blood pressure, can certainly disrupt heart failure. So people with heart failure particularly should be avoiding a non-steroidal anti-inflammatory. I mentioned previously, or from our question, most of you identified that someone with impaired renal function should not be getting an NSAID. NSAIDs can affect renal perfusion. So this is particularly when combined with an ACE inhibitor and a diuretic, has an acute effect on renal function. And the stomach and intestine, of course, these are the well-established effects that prostaglandins have in protecting the stomach lining from acid secretion. This is lost when someone is using a non-selective COX inhibitor, such as a non-steroidal anti-inflammatory. Minimal effects on the liver, and certainly in lung function. For people who are sensitive to aspirin, we know that NSAIDs need to be avoided because they can also trigger a worsening of their respiratory function. There are other effects such as cognitive impairment, but we won't go into those too much today. So I wanted to dive into a quick case study to give you some sense of the evidence out there and how that is changing. So here's Wayne. He's a former surfer. You can see he's former surfer because he's almost as wide as his surfboard these days. Still surfs though, so he stays active. Unfortunately, recently he had an episode of debilitating lower back pain. And he came into the pharmacy. He said, I've had some paracetamol. They didn't seem to work. So what are the management options? And what I'd like to do now is step through this case to look at some of the evidence, but also highlight some of the important things that Jack said in how we might assess someone in this situation. So he's come to our pharmacy, and we're going to now have a look at some of that background information. So one of the key things that Jack mentioned really is about assessing patients appropriately. And one of those tools is look for red flags. So things like fever might suggest infection, a fracture, of course, and a history of fracture. Use of corticosteroids might be predisposing of that. Unexplained weight loss. And of course, if someone experiences low back pain and urinary incontinence, that could be a very serious neurological problem like cauda equina syndrome, needs urgent referral. And all of these would lead to a referral. But studies have shown it's probably less than 1% might come into a pharmacy or a general practice or even an emergency room and actually have these as some of the reasons. And it does mean that most people with low back pain, even if it's quite severe low back pain, do not need an X-ray or imaging. We know that, of course, that carries some risk. It's cost to the health system, maybe even cost to the environment, but it would not change the way it would be managed or treated. So the first thing to do if you've assessed for red flags and then there's none there is to reassure that person, Wayne, you will get better over the next few weeks, as long as you can follow our advice. And the first bit of advice is not to lie in bed or stop doing things. It's about staying active. Maybe not back to surfing or back to, using heavy physical activity, but modest or moderate physical activity building up over time. So that activity and staying active can really help people recover, can reduce their pain, improve their function. So can we use medicines in that situation? He's already used paracetamol. Should we be thinking about an NSAID or an opioid, given my topic? And it is important, no matter what we do, that we say to Wayne, how about we review you in a week or two, and if you're not getting better, to then speak to your doctor or think about another strategy. So the first thing that Wayne did, of course, was to take paracetamol. And this was a study that I was lucky enough to be involved in called the PACE trial some time ago. I won't go into too much detail, but just to highlight that when we compared paracetamol taken regularly or just taken when required or a placebo, you can see here this is the number of people who have had recovered. So this is about having a pain score that was below either out of 10 between 1 or 0. And you can see that most people recovered, within 3 weeks. but there was absolutely no difference between taking paracetamol regularly or just when required, or placebo, suggesting that paracetamol, of course, really is not very useful. Our findings suggest regular paracetamol does not affect recovery time compared with placebo. So we're not recommending paracetamol, and this is now dropped out of a lot of practice guidelines around the world. I was involved in this study, though, which compared diclofenac, which is a non-steroidal anti-inflammatory, with a physiotherapy intervention. And this came after I was teaching physiotherapists, and I said, why do you do these manipulations? And this study turned into being physio versus the pharmacist. And really it highlighted how hard it is to do research in this area. So we were focused on people with acute low back pain. And unfortunately, when we compared physiotherapy, spinal manipulation, with or without diclofenac or placebo, and the other, so you can see we had 4 treatment arms here, you can see again, most people got well within 3 weeks. They were back to full recovery and activity, but there was no difference between these treatments. Because this was one study, and there's now been a number of trials that have looked into this particular area. And here's a systematic review, which was presented in the Cochrane Library. And you can see that NSAIDs seem slightly more effective than placebo for short-term pain reduction in people with low back pain. And you can see the forest plot there in our study, which was the Hancock 2007. But overall, when we look at all the evidence, this really does seem to imply that there is a small and maybe or possibly not clinical benefit for NSAIDs. But it does mean to say if a person is suitable for an NSAID, it's worth trying. We also know that this study and these data and other analyses have shown there's probably no difference in the pain relief between COX-2 selective or non-selective NSAIDs, despite different claims. So analgesic benefit is about the same. And from these trials, we could find no difference in the adverse effect profile between different NSAIDs, short-acting, long-acting, long half-life, short half-life, or even selectivity. No real difference between them. So that's worth keeping in mind, despite the claims that often get made about COX-2 selective agents. So this led us to our next trial, which was about opioids. And this trial just came out earlier this year, in fact, just a few months ago, where we compared oxycodone given with naloxone to a placebo. People were also given advice to stay active. They could also use NSAIDs if they needed breakthrough pain treatment. And what was interesting about this trial is we followed people over 12 months to look at whether or not a short course up to 6 weeks of low dose or modest doses of oxycodone in the acute setting actually were able to improve recovery. And what you'll notice from this is that actually from a pain intensity point of view, if you had previously, or if you've been taking an opioid, it seems after 12 months that actually your pain might be even slightly higher. And this is one of the possible adverse effects that we do see from people who use opioids for an extended period of time. So opioids did not improve pain relief, function, or disability. And there was even signals that your pain might be worse. And when we looked at potential for addiction using one of the screening tools, it seemed certainly higher in the opioid treated group. So this really was concluding in acute low back pain, opioids do not improve treatment, which was quite a surprise to me, given, I would think that if someone had quite, 6 out of 10 pain score, an opioid should provide some benefit there. This study, which is very recent, was also on the back of a previous review we did, which is presented here, looking at 20 randomized controlled trials in people with chronic low back pain in this particular case. And we looked at efficacy and tolerability, but also whether we could find any dose effects in this regard. What was interesting about this analysis as well is that for people with chronic low back pain who could tolerate the medicine, so they're often screened before they entered these trials, opioid analgesics provided only a modest short-term pain relief, but the effect was really not considered clinically important. What was very clear, though, was the risk of harmful effects was quite obvious in the opioid treatment group. So this was, again, that idea of opioids have a limited role in chronic pain, as our last speaker really highlighted, that we need to start to think about other interventions rather than perhaps medicines in this regard. So just to think about that balance of limited benefit for opioids What are the potential harms? Well, many of you would know these already. And of course, you'd immediately know that constipation can be quite a debilitating problem. And if you have low back pain and you're constipated, that's a very serious health problem that you've got there because you're in a lot of pain. So using a stimulant laxative is very important if someone's taking an opioid. We also know that these adverse effects are very much dependent on the dose and duration of opioid treatment, sometimes even the route, but they are relatively common to all opioids, and why combining opioids is not a pharmacologically rational approach because we can't adjust them. The central nervous system effects, of course, are very serious. The effect on the respiratory system, so cognition and respiration, are really critical. We also know that in the long term, where people might be using these for chronic pain, we start to see some other changes that are happening. Hyperalgesia, people are more sensitive to pain stimuli. We can also see immune suppression and also suppression of the HPA axis, which is putting people at risk of other types of health problems, as well as, of course, you'd be aware of dependence and the risk of withdrawal in this regard. So how do we summarize this case? First of all, I'll remind you that we screen for red flags, the advice to stay active and avoid bed rest and to get yourself back to normal activity slowly. We know that most people will benefit from some reassurance. I know it's quite painful now, but it will get better. If it's not getting better, of course, with that review, then we need to refer them. We may have missed a red flag. It is pretty clear, and I haven't been able to show the evidence for this, but application of heat and heat packs can often be a very good pain relieving strategy. Taking medication history becomes very important so that we can identify whether or not a person is suitable for an NSAID and obviously medical history. We'll think about time-limited use based on the advice to avoid possible harms. And I did actually mention there, if someone has responded well to paracetamol, for example, it's worth perhaps a trial of that if it's worked for them in the past as well. The evidence clearly says that the benefits are not adequate for opioids to outweigh the harms, so we should avoid those. And as I mentioned, in helping this recovery, setting clear goals. And that was something that Jack pointed out very nicely when we work with people on that biopsychosocial model of pain and the recovery model that is needed. So I might just, in finishing, cover very quickly another case here, just on a 72-year-old woman. You can see this is a bit more complicated, an older person. She's got osteoarthritis this time, but quite a history of medical conditions and a range of medicines that we need to carefully assess. And you can see here that we've got medicines that you'd recognize that are not uncommon in a 72-year-old woman with a range of medical problems. This is a review we did a little while ago on paracetamol, which highlighted that actually, again, looking at paracetamol in osteoarthritis, that the evidence is really quite limited and variable. And if there is any effect, it's probably quite marginal. So while the recommendation was often to start on paracetamol, it really does lean towards using a non-steroidal anti-inflammatory. But what is clear is that opioids do not help in this group either. What's of interest, though, we do see quite a lot of people using supplements in this space. So I'll just go back. Supplements in this space. And this was a recent review that we looked at a range of different things. And one of the medicines that's there is glucosamine. And it's really interesting. This medicine is widely used for osteoarthritis, but the clinical trial evidence really does not support its use and effectiveness in this setting. We are currently studying a number of these extracts here. So boswellia, which is also known as frankincense, pycnogenol, curcumin, you would be aware of, and MSM are all medicines that we're currently investigating in combination to see if they help. So just to summarize, as I wrap up, avoiding NSAIDs is really important in this patient. She has a range of comorbidities and medicines that would not benefit from an NSAID, and the risks would outweigh that. Consideration potentially of a topical NSAID, about 10% of what we apply topically is absorbed. So depending on the dose, that could be quite good. The limited role of complementary medicines I've mentioned, and also paracetamol, and avoiding opioids. Strong evidence that opioids do not help osteoarthritis because they limit activity and quite important. Again, staying active, heat application is important, but in osteoarthritis, as our other speakers highlighted, there's a range of other non-pharmacological strategies, including other health professionals who can really support people to regain that function, and that seems to improve pain relief as well. So everything from knee brace to water-based exercises become very important as well. So in summary, the quality use of analgesic medicines really is about weighing up the evidence of benefit and knowing it and avoiding harmful effects, and hopefully consider comorbidities and concomitant medicines before you leap into prescribing a medicine. So thanks very much.
So thank you. Thank you very much, Andrew. Very, very good discussion, very, very insightful discussion. So we would like, there were some questions that are answered already by chat. So
there was just one question there about the combination.
Still some questions.
There was a question there in the chat just about combination of NSAID, paracetamol, muscle relaxants for the management of pain. And actually, there's quite a growing evidence base for the use of simple analgesics and other medicines, including NSAID and paracetamol. In Australia, there's a number of products now available, and these are being available across the world. It kind of makes sense if you can't use an opioid, but you can use an NSAID. Combining it with paracetamol is not a bad strategy in recommended doses. And what people often do, some formulations have you take them together, but other people will stagger them. So paracetamol maybe in the morning, NSAID at midday, and these trials are still yet to be done, but it certainly shows that they do seem to combine, have some combined benefit. The combination with muscle relaxants is very weak, the evidence there. I've done a review of those studies in low back pain, and there's no real evidence that muscle relaxants do provide much help. And one of the widely prescribed medicines there is benzodiazepines, and there's certainly no evidence that they're helpful, lots of evidence that they're harmful.
Okay, so thank you. There are a lot of questions that we would find in the chat box. Some are answered, and in the interest of time, actually our speakers would want to answer them all, but we basically don't have time for that anymore. Things were made very clear on how we could, as pharmacists, manage pain, especially chronic pain of our patients. So we now go to the poll again. So for question number 1, which of the following have not been shown to influence persons' experience of pain? So please pick your choice. Okay. Okay, so for question number 1, we still have the answer that was given before we started, where 68% answered none of the above, all influence a person's experience of pain. So we move to question number 2. Okay. Question number 2 says, which of the following is not the primary goal of chronic pain management from a pharmacy practice perspective? Okay, 4 choices are given. Please pick your choice now. Okay. Okay, so again, same answer as we started. 83% chose maximizing the prescription of high-dose opioids for long-term use. Then we move to question number 3. NSAIDs should be avoided in which of the following 4 choices? Okay. Okay. So same. 84% answered people with renal impairment. So again, thank you very much. And I'm sure our participants who are in now, are one with me to say that there were a lot that we've learned from our 3 speakers sharing their expertise on how pain management should be done. In closing, I would like to thank in behalf of FIP, Beatrice, for the support given for this activity to happen. Of course, to our 3 powerful speakers who shared their expertise and time to be with us today. And our participants, our pharmacists who joined with us in this activity. And of course, to our 3 FIP team, passionate and very hardworking, Carola, Ruben, and Ali. So thank you so much. So again, this is Leonie Ocampo from the Philippines. So thank you so much and bye.